Well, good evening. I'm very pleased to welcome all of you to this Iowa State University Faculty Forum. This is the first in a series of forums that we will hold this fall that will address current issues. And the purpose of these forums is to better educate all of us, students at the university, faculty, staff, members of the community, about the various perspectives on important current issues. And of course, there's no better place to start than the topic of tonight's forum, healthcare reform, since it's such an important topic that is under so much discussion right at this moment. Later forums will address economic recovery on October 13th and global climate change on November 3rd. I want to thank the Provost Office in particular for taking the lead in organizing these forums, and several of our academic departments for providing the faculty experts, the ISU Committee on Lectures for their work in the detailed organization, and particularly our student leaders on the committee. And I'd like to thank Diane Bystrom, who is going to serve tonight as moderator. Diane is director of the Carrie Chapman Catt Center for Women in Politics. She will introduce our panelists, and then we'll moderate the question and answer period after the panelists have spoken. And I'd again like to thank all of you for joining us, and I'd like to ask Diane to come to the podium.
Thank you, President Joe Free, and I'm really excited to be here tonight. There really couldn't be almost a better night to have this forum than the night after President Obama's address to Congress last night on the issue of health care reform, and of course in this environment where we've had so many public forums on health care reform and the media coverage that has followed it. The political rhetoric surrounding this debate, especially as played out in the media, has been often marked by outbursts, arguments, tensions, incivility, and even physical fights. I think I can assure you tonight that tonight's discussion will be civil. In Iowa, we have a long history of civility in our political discourse, and we have a long tradition in Iowa of treating each other with respect, even if we disagree, and I assume that will be the course tonight. The political rhetoric surrounding this debate has also been marked by catchphrases, and I think we've all heard them, such as death panels, pulling the plug on grandma, and asking one citizen who asked a question to a senator, what planet had she been living on? Tonight we hope to shy away from the political rhetoric and instead focus on the reality of healthcare reform with our panel of experts. Joining me on tonight's panel are 4 experts on various aspects of healthcare reform. Each has been asked to give a 5-minute opening statement in the following order. And they're all sitting in order. Mark Emmerman is an economist and director of recruitment services for the College of Liberal Arts and Sciences. He grew up in a family without health care insurance and a community that made sure it was not an issue. Although Mark does not consider himself an academic student of health care reform or health care issues costs, he has conducted a number of studies on labor issues, patient choice, and facility viability on the basis of existing problems and the need for solutions that can be implemented. Our next speaker is Liesl Ethington. She's the director of the Regional Capacity Analysis Program and an assistant scientist in the Department of Economics at Iowa State. In her 11 years at Iowa State, she has researched and analyzed various aspects of Iowa's economy and its population, including population growth, migration patterns, poverty and income levels, including health care insurance coverage. She recently authored a report on Iowa's uninsured. Next is Doug Walker, who is an assistant professor of marketing in Iowa State's College of Business. Within the context of health care, he has investigated issues related to pharmaceutical marketing, prescription data availability, and resource allocation in health maintenance organizations, otherwise known as HMOs. Our last speaker is from the community, Dr. Michael Kitchell. He's a physician at McFarland Clinic in Ames and president of the Iowa Medical Society. He's a member of the American Academy of Neurology, which is his medical specialty, and director of Mary Greeley Hospital's Center's Rehabilitation Unit. Dr. Kitchell has testified before the U.S. House of Representatives Energy and Commerce Subcommittee on Health, and I believe he was just in Washington yesterday, so has really up-to-date information. As I said, I've asked each panelist to start with a 5-minute opening statement, and I'll give you a little subtle nod when you're toward the end of your 5 minutes. Following the opening statements from the panel, we will be opening the forum to questions from the audience. So first we'll begin with Mark Emmerman.
Thank you, Diane. You probably won't have to give me a subtle nod.
Okay.
As Diane said, I'm Mark Emmerman. I'm happy to be here tonight. Thank you all for coming. I'm not going to tell you how this should play out tonight. I'm not going to tell you what I think the right and wrong thing is to do with health care reform. I'm a person that tends to think that there's 1,000 right ways to do everything. And if we all get together, we'll find one that most of us can agree on. I think there's 3 things about the current discussion that strike me as noteworthy and that might be something you'd think about as you think about what kind of questions you want to ask and what you want to follow up on tonight. The first is that we're really looking at 2 things. We tend to talk about health care reform, but there's 2 parts to that, at least 2 parts in the current debate. One is, how do we provide insurance for the uninsured? Okay. The other is, how do we change the system to control the increase in health care costs? Okay. Those 2 are not very much separated in the debate, but they are 2 very different issues, and there are 2 things that we could address separately if we wanted to. The first of those, I think, how to ensure the chronically uninsured, is probably the easier of the 2 to solve. Okay? I'll just leave that at that. The second thing that I think should be thought about as we think about health care is that it appears, and it was reinforced last night, that the solutions that have a chance of rising to the top here will be based on a continuation of the current foundation of employer-based health insurance. Okay. That doesn't need to be so. There are advantages and disadvantages to doing that and not doing that. But employer-based health insurance has implications for the cost structures that we look at. It has implications for the cost of goods we try to export. It has implications for our options when we deal with Medicare. So it's a bigger issue than just saying we don't want to disrupt insurance as it stands now. I think the third important thing that I see when I think about health care reform as we're debating it now is that instead of trying to find common ground on what actions we need to take to make something work, we tend on both sides to define this in personal terms. If you are for health care, you might be called a socialist or any number of things. If you are for health care, you might tell your opponents that it's a moral issue and a social justice issue. And on the one hand, you've got one side telling the other side that they're economically or maybe politically irresponsible. And on the other hand, you've got the other side saying that their opponents are immoral or somehow not as socially civil as they are. And as long as we decide to couch this in personal terms and we make this a personal argument, we are pretty much assuring ourselves that we will do this again and again and again. Right? The trick here, if we can't find common ground right now, is to at least find parallel paths to a common horizon. And that's something that we as a nation are having a harder and harder time doing. But if we're going to solve health care, I think we've got to quit putting it in personal terms, and we've got to start coming down to what we can agree about with the numbers and what we will find as maybe not first best, but acceptable second best solutions. I'll just leave you with that. There will be facts and figures enough tonight. We've all seen millions of numbers on what it'll cost and what it won't. So, have I got my nod yet?
It's 5 minutes exactly. Perfect. I'm going to go sit back here. And next we'll hear from Liesl Ethelton.
And thank all of you again for coming tonight. Before I start, I want to go back a little bit and tell you about what I do. I have a great and fascinating job, and the reason I'm telling you is it helps explain my approach to looking at this issue. I study Iowa's economy and its population, and in doing so, I look for how things are changing and what the implications of those changes might be. The information that I find, I share maybe for people in a public policy setting, for business decision making, or for just people who are curious, want to know about their communities and how they're changing. I study a wide range of issues, anything from manufacturing job losses, poverty rates in different places, school enrollment declines, and my approach to each one of these issues is usually pretty much the same. I first look at the where and the who. And so that's what I've done with this particular issue. I'm not a health insurance or healthcare expert, but what I was interested in is who are the uninsured in Iowa and where do they live? What are their characteristics and where can we find them? So that's what I'm prepared to talk about tonight. The reason that we look at the where and the who on things like this is if we can start to identify patterns in the where and the who, then hopefully we can start to find out some of the why. And if we're lucky, maybe we can get to the how, is in how to fix it. So another important reason that we look at the where and the who, if we can find differences in the incidence of something across space, across communities of different size, maybe in eastern versus western parts of the state, or if we can identify differences in the incidence of something by kind of people, whether it's by their age or their race, it might help to explain both public attitudes about that particular issue and public policy approaches. And I think on this particular issue, it's become quite polarized, especially when we hear people talking about insuring unauthorized immigrants or taking care away from the elderly. So that's why I think the where and the who are very interesting here. My report, I'm just going to share with you a couple of the key points from that report. First of all, Iowa does have a relatively low fraction of uninsured residents compared to the national average. So that might suggest that public attitudes in this state, we don't think it's as much of an urgent issue. Or the opposite could be true because there are relatively few of them. We may not have as hostile attitudes towards certain groups, and so we're a little bit more amenable to changes at the federal level. Another thing that the report found is we do have pretty interesting differences across the state, just by region, in the incidence of uninsured population. A lot of people might think of it as a big city issue, where we have most of our immigrants maybe where they concentrate, or where we have high fractions of low-income residents. What I found was that actually, as a percentage of the population under 65, the incidence of uninsured population is highest in our most remote rural counties. So it's not just a big city issue, it's a rural issue as well. And then the third thing that I want to point out is in terms of the types of people who might be uninsured. We hear a lot of people suggesting that it may be by choice that they don't have insurance, or that it's only the low income, or that it's only the recent immigrants that are causing this problem. What I found, based on the estimates that I used from the Census Bureau, is that over a third of Iowa's uninsured residents are white, non-Hispanic, people between the ages of 18 and 65, whose incomes are at or above 200% of the poverty level. So these are not your typical people that you might think of as uninsured. So finding all of these things raises possibilities for studying what are some of the causes behind these populations or these areas that have higher incidence of uninsurance. And I think that's maybe a less polarizing way to approach it. Thank you.
Okay, thank you. And next we'll hear from Professor Doug Walker.
Well, good evening. I'm thankful to have the opportunity to speak with you tonight. Thanks for coming. Feel like we're shooting a moving target here a little bit on this issue. So if anything's happened in like the last 15 minutes, don't hold us accountable. We were already in the room here. What I want to do in my few minutes I have here is first just tell you a little bit about some of the research I've done, and then hopefully along the way suggest a few areas in the general debate that I might be able to make some kind of contributions along the way. I'm a marketing guy. I look at the pharmaceutical industry, and last year in the United States, $291 billion were spent on prescription medications. And what I looked at particularly is what is the effect of detailing. $7 billion were spent on detailing in the U.S. Detailing is when a salesperson shows up at a physician's office and promotes their particular brand of medication to them. What I have found, very generally speaking, is detailing does contribute to physician learning at some level, but it is conditional. And if there's any interest in that, we can talk about some of those things in a little bit more detail. But I think more interesting maybe for the general debate is there's this overriding question from a public policy perspective related to detailing, and is this: does detailing increase the probability of a physician choosing the best brand for their particular patient on that particular prescribing opportunity? In other words, does detailing help the physician make better prescription decisions? And if so, is it worth the cost? Details cost several $100s per trip, and eventually that's all going to show up in the cost of our medication. So that's kind of the way I've looked at that particular problem. I think the methods that I use in the research, I think would contribute to some of the more general questions, and that is structural modeling for policy evaluation is complex. We are trying to say, if we do this, this is going to happen. And we are looking at an extremely complex problem here with a lot of moving parts, and those predictions are very difficult. And what are the ramifications if we're a little off on some of those inputs to those decisions? So I think there's some interesting things there, too. Another thing I've looked at is data availability. The way it works in the pharmaceutical industry is when you go to the pharmacy and you give that prescription, I do the same, you do the same, all of those are consolidated, and then they're distributed to the pharmaceutical firms, researchers, whoever wants to purchase that data. Now, the patient-level data is scrubbed, but we know by physician, by brand, how many prescriptions that each physician wrote in each period, so that as compared to most industries I look at, the data is very rich. Right now, there is a lot going on in this industry. There's 3 states where there is a privacy First Amendment battle going on. And in those 3 states, one has banned the practice. The data is no longer available. One has banned, and that's been overturned. And then a third banned it. It was confirmed on appeal, and now the Supreme Court has refused to hear the case. So there's a precedent now where we can expect for this data to become less and less and less available. So the question is this: if detailing now is done, allocated by these pharmaceutical firms without knowledge of what prescribing is going on out there, assuming there's value in this detailing in the first place, the primary question is, will pharmaceutical firms be as efficient as they previously were? Is it just going to continue to be more inefficient and add to the cost of the drug? So there's a lot of things we can talk about there. And I think when you talk about these privacy issues, some of the things about electronic records comes into play. I think some of those issues can be somewhat interesting too. So anyway, thanks. Look forward to the discussion.
Thank you. And finally, we'll hear from Dr. Michael Kitchell.
Thank you. I wrote a 13-article series last year in the Ames Tribune, and they were pretty lengthy articles, if those of you who read them remember them. It's going to be hard for me in 5 minutes to kind of summarize those articles, and obviously a lot has happened, too, over the last year. I wrote about the coming crisis in healthcare, but it's really been here for quite a while. We have about 1/6 of our Americans who are not carrying insurance, either because they can't afford it or some of them choose not to have health insurance. There are too many gaps in healthcare in this country. We have some of the finest doctors and the finest hospitals in the world, but not everyone gets access to those hospitals and doctors. The uninsured in this country are sicker and they die earlier because of their uninsurance. We have the most expensive health care system in the world. We spend $2.3 trillion every year. When you hear the health care reform bills, when they talk about $1 trillion, that's over 10 years. We spend $2.3 trillion each year on health care. Now, $800 billion of that is in Medicare and Medicaid. A lot of that $2.3 trillion is subsidized by the government because we get our health insurance through our employers, and that is generally tax deductible. So over half of that $2.3 trillion is really going through the government. The government is funding $1.2 trillion in health care. As I said, we have the most expensive health care system in the world, and we spend almost 1.5 to 2 times as much as other countries like us. 1.5 to 2 times as much money per person. And unfortunately, even though we spend a lot more than other countries, we don't have that good results. We're spending a lot of money with pretty mediocre results when you compare us to other countries. Last night, President Obama said that there was agreement on about 80% of the issues in health care. And I'm going to talk tonight to try to clarify where some of the biggest differences are in the health care issues. Before I do that, though, I need to make sure that the audience here knows what I'm talking about. And so I'm going to have a little pop quiz here. So how many of you are pretty sure of what I'm talking about when I talk about a public plan or a public option? How many of you are pretty sure what I'm talking about? Pretty sure. Okay, so the rest of you are not too sure about what I'm talking about. So a public option is a government-run plan. Okay, it's a government-run plan. We have government-run plans right now. They are Medicaid, which is state-run, but funded partly by the federal government. And we have Medicare, which is obviously pretty well known to most senior citizens. Medicare works very well for our senior citizens. But Medicare is partly government-run and partly government-funded. 22% of Medicare patients are covered by private insurance. So you need to understand the difference between government-funded health care, and Medicare has government funding, and government-run. So some of Medicare is private insurance administered. Medicare has about Medicare and Medicaid have about 25% of the population covered. 25% of the population is covered by Medicare and Medicaid. About 56% of our citizens are covered by employer-sponsored insurance. Only about 7 or 8% of Americans actually buy their own insurance. Insurance bought by an individual is extremely expensive. It's about 3 times as much as people are paying through their employer. You've heard about the term rationing of health care. I'm going to try to not take a political side tonight, but I do have some comments about that, and I'll talk about them later. As I said, about 1 in 6 Americans is uninsured. About 16% of the population is uninsured. So there are more uninsured people than there are people on Medicare. There are more uninsured people than there are people on Medicaid. Medicare and Medicaid, like I say, are about 12 to 13% of the population apiece. So 16% is greater than 12 or 13%. So I'm going to talk a little bit about the public option because I think that's what a lot of people need to understand a little bit more about. So again, a quiz. Some of you have heard about a federal program, an insurance product that our senators, congressmen, and federal employees have. And it's an excellent plan. I hope everybody could get this federal employee health benefit plan. Now, the quiz is that a government-run plan or is that a government-funded plan? So who thinks it's a government-run plan? It's not. It's actually a government-funded plan. The government funds a health exchange, so people who are federal employees can get on this exchange and they can choose from a cafeteria menu of private insurance plans. So this is private insurance. Our government employees and our congressmen have federally funded health care delivered by private insurance. Medicare is government funded, and like I say, 22% of Medicare is run by private insurance. That's called Medicare Advantage plans. Now, some of those arguments in Washington revolve around the public option. A public option, as I said, is a government-run plan. So the quiz is the federal employee health benefit plan a public option? No, it's not. It's run by private insurance. Now you may say, well, what about the efficiency of our government and what about the efficiency of private insurance companies? And I'll talk a little bit more about that later. I don't have time to get into all the details right now. But I want you to know why some people are violently opposed to a public option government-run plan. And this is simply it for us in Iowa. If you had a public option, and that public option said that the doctors receive 30% less pay than California doctors, and the hospitals in Iowa receive 50% less funding, less pay for equal work. Would you think that would be a pretty good public option for Iowans to pay the doctors 50% less or the hospitals 50% less than the hospitals in California? I don't think you'd think that is a very good public option. Well, now you know why Senator Grassley and a number of other Iowa congressmen are opposed to a public option, because the concern is that if there is a public option, they will choose to follow that public option of 30% less pay for doctors, 50% less pay for hospitals. And that public option is present right now. That public option is Medicare. We've been complaining about Medicare for years at the Iowa Medical Society. I've taken that on as a personal crusade. So I will be nonpartisan tonight, and I know Medicare is a wonderful insurance product for our senior citizens. But if you look at the hospitals and the doctors in Iowa, we simply have to cost shift. The government doesn't pay enough for our care. Let me give you an example. I'm sorry if I'm running over 5 minutes here. I want to give this example. You may know some people have defibrillators. These are nice little electronic devices that are implanted into the chest of people who have cardiac rhythm disturbances. They might have sudden death if they don't have a defibrillator in. So that defibrillator, the machine itself, costs $30,000. $30,000 for that machine. Guess what Medicare pays the hospital here at Mary Greeley for that entire episode of care. The patient going into the hospital, the nursing care, the room, the heating, the air conditioning, the lab, the x-rays, the equipment in the lab, and the lab where they put the machine into the chest of the patient. What do you think Medicare pays for that $30,000 piece of equipment and all the nursing and all the, not the doctor's fee, but everything else for that patient's care? $29,000. So now, does that mean that Iowa's hospitals are donating thousands of dollars for Medicare every time a patient comes into the hospital? Yes, that's absolutely true. We have the same problem as doctors. We have a mammogram machine which costs $250,000 for the state-of-the-art digital mammogram equipment. $250,000. Medicare pays California doctors $44 for a mammogram. They pay us in Iowa $26 for a mammogram. Now you can do the math. I think we have some economists here. You can do the math at $26 a mammogram and $250,000 for the machine. And of course you have to have some techs to run the machine. And you have to have some space to put the machine in. And, you know, it's pretty hard for an economist to come up with a good reason for us to do mammograms at $26 a mammogram. Now, you may say, well, how are the doctors in the hospital staying open in Iowa? It's because we cost shift. Cost shifting in healthcare is the name of the game. We have cost centers and we have profit centers. And the cost centers are basically the Medicare patients. The hospital makes money off some patients, usually private insurance patients, and loses money on Medicare patients. If we had a public option in Iowa and we traded those private insurance patients for those money-losing Medicare patients, I'm sorry, we just would have to close our doors, or we'd move to California, of course. But in any case, cost shifting is a very serious problem. The private insurance companies in Iowa pay doctors 70% more for the same services as Medicare does. Some doctors, for example, anesthesiologists, they get paid $18 per unit of care. It's about 15 minutes of work, $18 per unit. The insurance companies pay $50. So in other words, Medicare is paying 36% of what the private insurance companies will pay. Now, as the president of McFarland Clinic, you might imagine, how do you get your doctors to see those patients when they get 36% for this patient and 100% for that patient? It's a challenge, and you can see where if we didn't have cost shifting in Iowa, we wouldn't have too many doctors left. So I'll try to wrap things up here. I'm going to talk a little bit more about what I think is the serious concern, like Mark talked about, and that is we've got the problem of the uninsured, but we also have unsustainable costs. And those unsustainable costs have to be addressed. If there's one thing we have to do, it's get these costs under control. The first way we can do that is reduce preventable disease. We have an epidemic of obesity. We have too many cigarette smokers. We have too many people who don't do the right thing to keep themselves in good health. Secondly, we need to reduce costs that don't contribute to patient care. There are administrative costs in private insurance that are not helpful for the patients. We need to have value-based decisions. I'm an expert on paying for value. If you want to pay for the most expensive health care in the world, that's what you're getting, is the most expensive. I've been a proponent of paying for the most effective care in the world. And in Iowa, we are rated number 2 by the Commonwealth Fund in quality and efficiency. There's no other state that has a higher ranking of quality and efficiency than Iowa's physicians. We need to base our decisions on health care on value, and we need to make health care more efficient to keep the costs down. I can answer questions about the bills in Congress. I have a lot of the details if you want to know about them. Again, I wanted to tell you what are some of our concerns about the public option. As you know, President Obama last night said that he would be agreeable if the public option was not part of the health care bill. So again, I'll answer some other questions if you have some. Sorry that I ran over.
Okay, thank you, panelists. Now we're going to turn to questions from the audience. As you can see, there's a mic in the center, and I think Pat Miller is also going to help. I don't know if she is going to pass a mic around, but we'd like you to come to the center. Just as our panel of experts were asked to be brief in their opening statements, those who ask questions also need to be concise. In interest of time and the fact that we would like to allow as many questions as possible, we ask that you ask a question and not give a statement when you come to the mic. We're really interested in your questions, not in your statements. So please put your answer in the form of a question, I guess to say. You may direct your question to an individual panelist or the entire panel or a couple of the panelists. And we'll begin with questions now, and you can just come again to this, or I guess Pat's going to pass the mic around. So.
Since I think I was the only one that answered the question incorrectly, and I frankly was covered by FEMA, so your question was clearly stated, but the brain was obviously not in gear. I would like to throw a pop question at the experts at the table. How many of you can explain to me the medical system in Rochester, New York, that was in existence from the middle 1930s till the middle 1990s?
Okay, who would like? Dr. Kitchell? Okay.
Mike?
Yes,
You know that
I
one?
believe you're talking about the Kodak company-sponsored HMO.
That's a very bad description of it, but
Okay.
you're in the general part of the state.
Okay.
Am I right? The other three of you are ignorant of that?
Yes, I am.
Okay. So my question is, why don't we take what worked at one time and implement it and get on with it? The system in Rochester is too long to explain. I will not make a lesson, but if you'd like to stay around, I can do it pretty well because my son was covered, and I did check it. And they provided medical care at about 2/3 the cost that the rest of the country was providing it. Now, if they could do it for 60 years in Rochester, why can't we do it now?
Okay, Dr. Kitchell?
Yeah, I would love to answer that question. There are many systems in this country that are delivering high-quality care at very reasonable prices. You may have heard about a system called a co-op, a cooperative. There's a cooperative in Seattle, and it's called the Puget Sound Cooperative. It's a not-for-profit organization. It's a prepaid system. In other words, it's a health maintenance organization. The people there are very happy with their care. They get excellent care. Kaiser Permanente has a number of hospitals and doctors all over the country, on the East Coast, on the West Coast, where higher quality care is given at very reasonable prices. Many of the people in California go to that system because they're having difficulty with their care otherwise. So the way that those systems do better with their care is they are an organized and integrated delivery system that does not have the wrong incentives for health care. We incent our doctors to do the most expensive treatment. We don't incent our doctors to do the right treatment. So if you have the right incentives, you will do much better with care. I can talk about this a little bit more. This is one of my favorite topics, is paying for value. But I'll see if there's some other questions.
Okay, our next question.
My question is for any of the panelists who care to take a stab at it. Just assume for a moment that you were starting from scratch with the basic premise that you wanted everyone to have insurance. What would your system look like?
Okay, who'd like to take that first? Mark, can you address that?
I think if I started, if I started with the premise that I wanted everybody to have health care insurance. First thing I'd want is I'd want to make sure that everybody had basic care without any problems. Second thing I'd want to make sure of is at some point in time there was a marginal cost involved. Otherwise, people will not ration their own care. And at some point in time, the population needs to ration its own care. But beyond that marginal cost that was involved, you would want to have something that took care of catastrophic illness, right? You don't want people to fall off the margin and fall way off the boat. And without, saying the numbers are magical or they're right or something, you could imagine having a system where the first $1,000 in health care for an individual in a year was covered. Maybe the second $1,000 in health care in a year was out of pocket. And beyond that, you did a 90-10 or an 80-20 or whatever. Underneath that, you put I hate to call it public option because that has connotations here, but you put an insurance or an assistance plan under it so people that could not pay that second $1,000 would not stop their health care at the first $1,000. Now, you'd have to do that in a way that still gave them an incentive to ration their care. You could, for example, put a $1,000 account in each of their name if they were on the assistance program, and they could use that to pay for that second $1,000 worth of care, and at the end of the year, whatever was left was theirs. That way you provided them assistance, but you also provided them some incentive to ration their own care. Okay? You could do something like that. You could set that up either as an employer-based insurance program, like we do things now, or you could set that up where it was individual-based insurance. At this level, it doesn't matter. There are implications beyond the question at hand that might be impacted by that. But I think the main thing is you want to make sure people don't fall through the cracks, but you want to make sure people have an incentive at some level to make personal decisions about their health care and have a personal investment in that, without having people go bankrupt because they couldn't afford the care they needed, or without having them go dead because they didn't get the care at all. Okay?
Okay.
Could I just make one comment? If you read the details in this 1,000-page bill of the House and of the Senate Finance Committee with Senator Baucus, you will see that some of those ideas that you mentioned, which are very good ideas, are going to be taking place with this new product. This new health care plan, again, it's not a public option. This new health care plan, it's a health exchange. You can choose from insurance products. They will have standardized products with standardized rates, maximum of out-of-pocket costs. They have a range of the copays. So again, it will give people some incentive to not want that CAT scan or that MRI scan just because they have a headache and they want to make sure they don't have a brain tumor. So that is a way, that's a good suggestion, and actually some of these suggestions are in this health care bill. This health care bill has a lot of good ideas in it, and we need to get it passed.
I'd like to say one thing that I think is interesting. We hear a lot of talk about providing insurance for everyone, but I think most of the people that are proponents of that are what they're really saying is we want to provide health care for everyone. There's basically two classes of people that don't have insurance that would like it. There's two reasons they don't. One is they don't have the income to pay the premiums, or number two, they have a pre-existing condition. In both cases, if you just think about the role insurance plays in a financial system, in neither case is insurance the proper solution for them. Number one, if you have very few assets, you have no risk to insure. Therefore, the insurance is not the right avenue. If you have a pre-existing condition, let's say you have a condition that requires $40,000 worth of medications per year. Well, no one is going to insure you for any value less than $40,000 per year because that cost is going to happen for sure. For there to be risk to be insured, there has to be uncertainty in the cash flows occurring. So what we need to think about for the uninsured, particularly the ones that would like to be insured, insurance is not the answer. It makes no sense. It's just really who is going to pay for their health care and how is it going to be paid for, because both of those groups are unable to do it.
Could I make another comment? When you think about who's going to pay for health care, only 1% of the population is wealthy enough to cover their own health care bills. So we have to have someone else pay for the care of those people who fall ill. None of us is unlikely to have some health care problem until we drop dead. We are likely to have some health care problems, and we are likely to have very expensive health care problems. So if we don't have, other than 1% of the population, able to pay for their own health care, we've got to pool our resources. We either have to pool that through our taxes, or we have to pool that through our insurance. We have to pay for insurance. And again, this health care bill is going to keep the insurance companies from having exclusions or higher prices for pre-existing conditions. But the insurance companies are only going to do that. In other words, they're only going to not restrict people from buying insurance because of their pre-existing conditions. The only way the insurance companies are going to allow that is to have everyone buy health insurance. So please don't be shocked if we are required to buy health insurance, either through the government or through an insurance company.
Okay, we'll have our next question, please.
Okay, you talked about how there are great ideas in this healthcare bill, and I want to just focus on two of them and the amount of money that could be saved from them. And the first is recently added in, as President Obama said last night, and it is tort reform on the amount of money that we could save from people potentially suing their doctors, and maybe how much. Is there the availability of a cap, and how much do you think we would actually save on that? And the second question I have is, with preventative care, how much can we save from those later problems, do you think? And how much would that affect the problem as opposed to a public option?
Okay, tort reform and preventative care. Any thoughts on those topics?
I'm perfectly happy to answer these questions. Let's talk about the liability or defense of medicine. I don't think you'll find one doctor in this country who doesn't think we can't save a lot of money if we can stop the practice of defensive medicine. Every doctor in this country is afraid of getting sued. Every doctor is doing unnecessary tests and treatment. Now, you may argue about how much that is. Some experts say it's $80 billion. Some trial attorneys say it's only 1% of the costs of health care. And it is true in Iowa, we have actually very low premiums for my malpractice insurance. I'm not paying a lot of money here in Iowa for malpractice premiums. That's not the expense of liability and malpractice attorneys. It is the practice of doing more tests and treatment because the doctor doesn't want to get sued. We have to do tests and procedures to keep from getting sued. And so people need to understand that we could save a lot of money on health care if the doctors weren't so frightened about being sued. Now, the question was about caps. I'm sorry, I don't think caps are going to succeed. We do want liability reform through a couple of things. Number one is the certificate of merit. That will stop the frivolous lawsuits. We have to stop junk lawsuits. Secondly, there's what's called early information. If the doctor admits to a patient that they made a mistake or had a problem, that will keep that will make the patient less likely to sue the doctor. So we do have some ways to help. So I don't think tort reform right now is really going to work through caps. Obviously, some states have done that. Texas has done that. They think it's really successful. I don't think, even though my doctor colleagues want caps, I don't know that that's going to succeed. The second question she had was about preventive medicine or preventive care. No question, we need to have more preventive care. The problem is it's going to take a long time to pay off. But if we don't start now with preventive care, we are going to have even more of an epidemic of diabetes and complications from vascular disease. We spend $250 billion on cardiovascular care in this country. And if we just had people who'd watch their blood pressure, exercise more, watch their diet, don't get diabetes because they're overweight, we do need to make changes in preventive care.
Can I add something too? On the issue of preventive care, potential savings extend well beyond just the healthcare issue, given that that is one of the primary causes for bankruptcy is a catastrophic or chronic illness that people can't pay for their care. They can slide into homelessness. They can not be able to work anymore. All of these things have costs. And so if we can improve the preventive care, I think we will begin to see savings in other areas of government service provision if we can prevent some of the outcomes that are a result of these kinds of illnesses.
One last point. I think it needs to be pointed out that preventative care isn't something that we necessarily need health care reform to get the biggest benefits out of, because the most important parts of preventative care are self-administered, all right? If we are really going to get what we could get out of preventing disease and discomfort in this country, that's something that we all have to start doing for ourselves, okay? The obesity, the lack of exercise, we could get religion even if Congress never does anything, okay? But that's something we have to do ourselves. And if we don't do that anyway, we will never gain nearly the advantages that we could have out of preventative care at McFarland Clinic or Mary Greeley Hospital.
Mark, I have a kind of a follow-up on that. What about some of the companies that are putting things into play now that if you don't smoke and if you do exercise, they're basically giving them benefits, lower premiums, maybe a cash benefit? Do you believe that something like that would be a good incentive for companies?
I think incentives for living healthy are good. I also think that we can carry those too far at times. There are some differences, and one of the reasons that I can't sit and say everybody here's got to go out and run 5 miles and get healthy is because really we have a certain freedom for lifestyles in this country. So I think they are good. I'm not sure we can mandate them all. I think it's something that is got to be self-administered. One of the things that I see in most of the options I see in the healthcare plan is that we are looking at qualified plans and we are looking at community rating, which takes a lot of the incentives for getting religion on preventative care, particularly self-administered preventative care, off the table. So I'm not sure what a company's ability to maintain those benefits, particularly in terms of their health care benefits into the future will be if we have the health care reform proposals that are on the table.
Okay, let's go to our next question.
I don't want to be the only one that doesn't get to talk about preventive care.
Okay.
I got my 2 cents worth. No, really. A lot of times I think when we think about it, we think about very inexpensive procedures. But my wife's an optometrist. Does everybody at age 50 need a visual field, or just those that are at risk of glaucoma? Not a cheap procedure. Does everybody need a colonoscopy at age 50, or just those at risk for the diseases that maybe could find? So we're not necessarily always talking about cheap, inexpensive things or preventive care. Sometimes it's expensive diagnostic testing that can stop something very expensive down the road, but maybe can't do it for everyone.
Okay, thanks, Professor Walker. Okay, our next question.
I guess I have 2 points. One is in talking about people taking personal responsibility for rationing their care, I'm not sure how that would work if you, I've worked in nutrition education for years with the public, and there's a lot of misinformation, and there is a lot that people don't understand about just basic good health nutrition. How can somebody, if I don't understand my disease, if I don't understand the research, if I don't understand the options that are available, how can I effectively ration my care for a quality outcome?
Alice?
I don't believe that when we look at self-administered care, we ask people to do a better job of taking care of their own health, that we just close the door and say, go do it. Certainly there's people that have conditions that are complicated enough that it is hard to understand or it's beyond what they're going to pick out of reading a medical text. Providing services to help people understand what they need to do would be a lot cheaper in most cases than dealing with the consequences of not letting them know. So I don't think the suggestion is that we just close the door and say, heal yourself. And there is room for guidance on those sorts of things.
Let me ask you a question. Isn't it true that compared to, say, 15 years ago, you really can, on your own, find out way more information about your particular condition than you ever could before?
Yes, there is certainly more information readily available to the public, but I also agree with Mark. Unfortunately, we have a problem with health literacy in this country. Many of our adults are not able to understand a lot of instructions. They've done some studies on people who leave the doctor's office or who leave the emergency department, and unfortunately, a lot of people don't understand the instructions. So it is difficult, but I think we just need to continue with an educational program. I think the other thing that you need to do is change the payment system for doctors, because our primary care doctors, the doctors who actually talk to you and help guide you through the healthcare system, help coordinate your care, those doctors are underpaid. And if you think that your doctor doesn't spend enough time with you, it's because that doctor in Iowa has to see so many patients. He or she has to keep running on a treadmill all day. And so again, we need to change the payment system for our healthcare professionals. We need to have doctors work in teams with nurses, with nurse practitioners, with physician's assistants. And those teams of professionals can help to educate people. The doctor doesn't have time to do all of the education. We need to have a healthcare system that actually has what we call health coaches, or people that can actually help people. They've done studies on chronic disease. For example, diabetics, congestive heart failure, chronic obstructive pulmonary disease. Those are very expensive diseases. If you can keep those people healthy and keep them out of the hospital, you can save a lot of money in the healthcare system. They've done studies using teams of professionals, health coaches, doctors, nurses working together in patients who had congestive heart failure and chronic obstructive lung disease. They reduced the admission and readmission rate to the hospital by 50%. So were the patients happy that they weren't in the hospital so often? Yes. Were the insurance companies happy that they didn't have to pay for the hospitalization? Yes. So why don't we incent doctors to work in teams with health coaches to keep people healthy and keep them out of the hospital where they spend so much money per day? So again, my answer for you is we need to have a better health care system, and it doesn't revolve just around doctors. It revolves around teams of professionals that are actually rewarded for keeping people healthy instead of just treating them, sending for a helicopter to get them to a tertiary care center. So we need to invest in what we call primary care, coordination of care, and the healthcare system has to change. Our delivery system is screwed up, and we've got to have some reform. This healthcare bill will take a few steps toward that. It's not enough, but we'll hopefully make some progress.
Okay. Provost
Then
Hoffman?
I heard I suppose on public radio, they were talking about a population of uninsured people and said that they found that a third of those were actually eligible for some kind of a program. And I just wondered what you found in Iowa. Thank you.
Liesl?
In my research, I don't know the reasons that people are uninsured, but my colleague here, Kim, who I just spoke to yesterday on this issue, actually has looked at this with specific population groups. And one of the things that she said they're particularly interested in is the relationship between housing, food security, and health insurance. And this is particularly an issue among groups like the immigrant population or low-income people, One of the things that we see, though, with these groups is they're not always aware of the services and the programs that are available to them for a number of reasons. And so I wouldn't be surprised if there are a large number of people who could get into programs or who could get care who just simply are not aware. And they're juggling so many other issues that they really don't have the luxury of sitting on the internet and learning about these things. There may be language barriers, there may be education issues. So it's an outreach issue, I believe, and education.
Yeah, I think of the 46.6 million figure we always hear is a census figure. I think that is correct. And that, all it says, you either have insurance or you don't. It doesn't say if you could, if you applied. It doesn't say if you want it or not. I've seen estimates all the way from 8 to the 46 of those that want insurance and can't get it. So it's somewhere between 8 and 44 million.
Okay, Provost Hoffman.
Okay, I'm going to ask a question that I could answer myself, but I'm not going to. I'm going to ask you to answer it. You're all talking around the issue of what we in economics call adverse selection. So I think it would be really important for the audience, many of whom may not understand adverse selection, to explain why is it important from a cost perspective to have everyone insured.
I'd love to.
Please do.
And he's not our economist, but he'll.
But I've hung out with the economists.
That's right.
You got to do a little.
Okay, Professor Walker.
Yeah, I think the primary thing is if you have a pre-existing condition, is the premiums to actually cover your cost are prohibitive. Therefore, to include those in the system, they will have to pay less than the present value of their expected care. Therefore, there has to be somebody paying more than the expected value of their expected care. And adverse selection means this. Let's have a plan. It's this much each, and you have half the population that value is lower than their expected value of their insurance, and the other half where that value is higher than their expected value of their insurance. Those with the lower are in, those with the higher are out. And that's exactly what you're talking about. Here's the thing that bothers me about it, is when you have these two groups, neither of which are paying an amount that is correlated with the amount of health care they're going to consume. What you have lost when that happens is the financial motivation to maintain good health. Now, there's all other kinds of reasons for good health, but think about it this way. I like to smoke. I don't smoke, by the way. There's a smoker. They enjoy smoking. They see all these reasons that I should smoke. I know it's bad for me. I might have health problems down the road, but I'm weighing these things out. I'm going to smoke. But if you now put on, I'm financially responsible for my health care problems down the road, maybe that's enough to tip the balance to moderate their behavior. If you don't have that financial incentive, now we have to go in and try to change people's behavior via laws and taxes. Tax cigarettes. Makes them a little less likely to want to smoke. Or wear seatbelts, because if I get in a wreck and get injured, other people are going to have to pay for it. So she's exactly right. You got this balancing act, but it's a little concerning to me when you disconnect the value you pay to the expected value of the health care that you're going to consume.
Could I talk about that? Mm-hmm. We have a couple of nephrologists, kidney specialists at our clinic, and the percentage of Medicare patients that they see is about 98%. Because when people have kidney failure and they go on dialysis, the insurance companies will drop them like a hot potato. So if you wonder why Medicare has such high costs, it's because as we all get older, we're going to cost more, because as we turn 50, we're going to have heart disease, we may have more cancer. So as the age goes up, the cost of care goes up. So to make the insurance companies accept those people with diabetes or chronic disease and not kick them out or keep them from coming into their insurance, we have to have healthy people buying health insurance to balance that high cost of care. And like I said earlier, the insurance companies are willing to do that They're willing to take on these people with pre-existing conditions and not kick out people who get sick as long as there's a mandate that everyone, healthy people included, the young invincibles as they're called, they have to buy insurance. Now the new law, the new bill, is going to still have age-related premiums. In other words, younger people will have cheaper premiums. Older folks will have more expensive premiums. But for someone who is already sick and gets laid off from their job, an insurance company won't touch them unless they want to pay $100,000 for their insurance. The only way they're going to get insurance is to become disabled, and then they can apply for Social Security and Medicare. So those are the people that fall through the cracks in our system right now. And the only way we're going to get the insurance companies to cover the people that are sicker, the adverse selection, is to allow the insurance companies to rate their premiums by putting healthy people into the mix. So it's pretty simple. They're all, like I say, who can afford to buy their own health care? Only 1% of the population. The rest of us have to pool our resources, and we've got to have healthy people who are not going to cost money into the system.
Well, Pat's signaling that we have time for 2 more questions, and they're up here now. Anne, would you like to ask a question, please?
Yes, thank you, Diane. I've had the dubious pleasure of being involved in healthcare policy, law, and reform for over 20 years. And so I'd like to direct this question to Dr. Immerman. This current reform effort seems to be particularly acrimonious. And you mentioned earlier that having things couched in such personal terms was a detriment. And I'm curious as to what advice you would give politicians in terms of couching it in another way.
First off, I'll start out, maybe it's the wrong answer, but I'm not sure it's a politician problem. The old saw is that we live in a democracy, and in a democracy you get the government you deserve. At some point in time, when we talk about incentives for doing the right thing in healthcare, we have to realize that our politicians follow the incentives we give them. Okay? As long as we are willing as a society to decide that rather than finding middle ground, it is in our best interest to see if we can stake out a position so far from middle ground that we can move the middle to where we'd really want to be, we are going to stake out our problems in personal terms. And it's not just politicians. If you read the editorials in the Des Moines Register or the Ames Tribune, if you listen to most any debate, you will find that for some reason in this country, changing our mind or being swayed has become a sign of weakness rather than a sign of flexibility or maturity. And I think our politicians reflect us in that and not the other way around. So maybe that's the wrong answer. It's probably not the answer you were looking at, but I think our politicians, just like our doctors and our insurance companies, follow the incentives that are placed in front of them. And I think the tone of the debate in Washington reflects the tone of debate in Ames rather than the other way around.
Thank you. Okay. And our final question.
I've been aware of the inequity in Medicare reimbursements that Dr. Kitchell referred to, and I've thought about it for some time. That's certainly a very troubling thing. I believe I'm correct in saying in Iowa isn't the only one. There are a number of areas of the country. And I don't know how they decide these things or what the deal is, but it strikes me that there should be legal grounds, for suing under the Equal Protection Clause. I could see, medical associations and attorneys general and banding together, and why haven't those of us who are being beaten down, haven't we sued under, equal protection claim?
Okay.
Yeah. you've just touched upon my favorite topic, is geographic inequity. And I'll try to keep this short because I could probably talk for a couple hours on it. But yes, Iowa is not the only state that has very low payments. If you look at the Medicare payments per patient, the Medicare payments per patient, not per doctor, not per hospital, the Medicare payments per patient. In Miami, Florida, they are $16,300 per patient per year. Right here in Ames, they are $6,200 per patient per year. In other words, we are saving the federal government $10,000 for every Medicare patient that we have here in Iowa. Yes, we're angry about this, and the Iowa Medical Society and I have had this as one of our primary concerns for many years. I've spoken out against this for, this is about my 7th year. The Iowa Medical Society has now gotten enough money to proceed with a lawsuit against Center for Medicare Services. And in fact, we've had some legislation that has not gone very far because, unfortunately, in the House, those states like California, New York, Florida, Massachusetts, they have higher payments, and so their congressmen do not want to equalize those geographic payments. The Miami congressmen are getting together with Florida, with the other Florida congressmen in California, and unfortunately, there are more of those than there are rural legislators. So that's why we have not been successful. And that's why I think unless Senator Grassley, Senator Harkin, and Bruce Braley, a congressman from Northeast Iowa, if they are successful, we will not go ahead with the lawsuit. But basically, we will if they're not successful this year.
Okay, Lisa?
Yes, not only are we paying taxes to the federal government and the money is not coming back to Iowa, it's going to Florida and California and New York, all of us in Iowa are paying higher medical insurance premiums because the hospitals and the doctors need to get paid. And so the private insurance companies are generous here, and they actually make people who buy insurance in Iowa pay more to make up for what Medicare doesn't pay. Now, you may say, why can't we get the attorneys general in these other states to help us? And it's been very frustrating. I don't really have an answer to that.
I think Lisa had a comment.
I do, and I don't want to comment on your pet issue. I just want to give everyone else something else to be angry about. We have other geographic inequities in Iowa. The average Iowa wage and salary worker does earn just 80% of the U.S. average. And for our non-farm proprietors, these are our sole business owners, our entrepreneurs, it's actually more like, well, in our non-metro areas, it's 52% of the national average. So we do have lower earnings here. The cost of health care, even provided by our employers, is a little bit more equalized in terms of what we pay for insurance. So what we pay is a much larger chunk of our earnings in this state than in other states. And that is something that Iowans, even the ones who have health insurance, should be concerned about. It's eating up a bigger and bigger portion of our paychecks here. And it's especially an issue for small business people and sole proprietors.
To give an idea of what the value is or what the size of the gap is in terms of what insurance companies pay over and above what Medicare pays. In Iowa, an insurance company pays about 150% of the Medicare rate for procedures in the hospitals. And if you think back to the rates that were given to you earlier on the differential between what private insurance pays to a doctor or hospital and what they pay and what Medicare pays to a doctor or hospital, those numbers run true. The estimate is that health insurance premiums in Iowa are between 11 and 13% higher because of that. And it's not necessarily just that insurance companies are generous in doing that. Insurance companies depend on two things. They depend on patients and insureds to pay premiums, and they depend on some place to send those insureds for service. And if they don't pay the extra in Iowa, as we heard before, the hospitals and the clinics close their doors. And if that happens, you don't have insurance. You don't have profit for insurance companies. So it's not necessarily altruistic. It's a question of surviving, okay? And that's what the payment differential does. But for everybody that has insurance, it's about 11 to 13% extra. That is basically an indirect tax on employment in Iowa to support the Medicare system.
Okay, I'm actually going to end with the last question, but I'm asking for simple yes and no answers. You know, I'm from the area of political science. We love polls and things like that. So I'm going to poll the panel, and the question is this, a simple yes or no. Will health care reform be passed by the U.S. Congress before the end of this year? Mark?
No.
Liesl? Yes. Doug?
I think probably so. Yes.
Yes. Okay. Dr. Kitchell?
I was in Washington yesterday, and I heartily say yes.
Okay. Well, 3-1. Write that down. Okay. Oh. Okay.
Could I ask that we extend our time frame tonight by consensus? I think there are a lot of other questions that people would like to ask.
Yeah. Is that what you want to do? You want to close it, and then you can stay around for some questions to have people come up? Okay, we'll do that. I want to thank you all for coming tonight. Thank you especially to President Joe Free, Provost Hoffman, our panelists, and the Committee on Lectures for sponsoring tonight's forum. As Dr. Joe Free said when he opened this is a series of faculty forums sponsored by the Office of the Senior Vice President and Provost. Our next faculty forum will be on economic recovery. We'll also have some economists on that panel as well, including Peter Rosum, who's in the front row here. And if I've neglected someone else on the panel, I apologize, but I know Peter's on it. It'll be held at 8 o'clock on Tuesday, October 13th, right here in this room in the Great Hall, and I hope that you can come to that. Again, thank you so much for coming. Thank you to our panelists. And thank you for your civility, and I'll be calling this into CNN later or put it on YouTube, okay? And feel free to come up to our panelists and ask your questions.